Welcome, everyone. We're back for another year of walking through our white paper analysis that we've done in partnership with the Health Action Council. Before we jump into that topic and all the different details that we're going to cover this afternoon, we'll start with introductions. I'm Craig Kurtzweil. For those of you that have attended this conference in person or have seen the materials in the past, this is now the 4th year in a row that we are presenting this joint study on behalf of Health Action Council. I'm part of UnitedHealthcare and I lead our Center for Advanced Analytics, which really focuses on these types of studies that we can bring to the industry to really show a new way to look at healthcare data. And with me is Angela Whaley. Angela, I'll pass the ball to you to do a quick introduction.
I'm Angela Whaley, and as Craig said, I am an advanced analytics consultant here with the Center for Advanced Analytics. This is the 3rd of these white papers that I have worked on, and it is always the highlight of my year. We're really happy to be back with you today.
Yeah, this is definitely the fun stuff. So hopefully you guys think it's fun as well. We've taken a little bit different spin at this year's white paper. In the past, we've done, again, 3 straight years of white papers. This is now the 4th year. In the past, we've done lots of interesting studies looking at the impact of virtual care, which is obviously very important this year. We've looked at community health. We've looked at generational analysis. And this year we take a little bit different spin, but before we even talk about the detail in the topic, we've really taken a wider range view of what's happening across the healthcare system with a partnership, looking at data not just from a medical perspective, but bringing in data from a pharmacy perspective with our friends at OptumRx, as well as broadening our medical perspective, including that data from our UMR partners as well. So that data will be blended out throughout the study. But really the highlight and what we're going to focus on today is what we call finding the uncommon in healthcare. And really what that means is looking at the ability to look at the variety of care and the high variances that we see within the healthcare system. So if we look at the next slide, I'll give you an example of what I mean. When you look at what's happening across the United States, whether it's utilization patterns or prevalence patterns or outcome patterns, there is a wide variety of outcomes that we see in our healthcare system. As an example, in the map view you can see here, this is looking at social determinants. And as we've talked about in past papers, where you live drives a whole lot around the healthcare you're going to receive and the health outcomes you're going to have. And if we look at that across the United States, overlaid with Health Action Council membership, you see a wide variety, pockets of deep red, pockets of deep green, where we see better or worse headwinds when it comes to social determinants. Hopefully today, as we focus in on the Health Action Council membership and specifically into these key conditions in the bottom right, we're going to show you that even within these common conditions, there's a wide variety of care that's being received within your populations. On the next view, we take a deeper dive into those populations and those conditions. Why do we focus on these conditions? Because we're all struggling with them. We'll talk about some of the numbers behind them, but they're key conditions that face every population. But again, we're not going to just look at them in total. We're going to look at them across subpopulations. We're going to find those anomalies. We're going to find those outliers, looking at things by age, gender, ethnicity, income, all sorts of different cuts and slices that we'll do within this study and that we'd highly recommend that you do within your population as well. In the next view, we look at why this matters. As we look at those populations, they drive over half of your population, over 60% of your population has one of these conditions. We know it drives an exponential portion of the cost and the trend. We'll talk about that in a moment. And most importantly, these are conditions that we can actually do something about. These aren't just gravity issues that we can't really impact. These are things that through communications, through the right plan design, through the right clinical choices, we can make a dent in some of these conditions and really improve employer well-being and lower total cost of care. In the next view, we look at the trends across Health Action Council. In total, we've had really good trends in our partnership with Health Action Council. But as you look at some of these conditions, these are the conditions that are actually driving trend as well. Asthma, back pain, diabetes, hypertension, and behavioral health. Those 5 conditions drive most of the trend that we see in a population. The rest of the trend is really actually negative. We're seeing some of those trends actually come down, but these areas we're seeing increased prevalence and increased cost, which is why we focus there. Next slide. As we dive into those conditions, we'll start with asthma, and Angela and I will go back and forth a little bit, but as we dive into asthma, let's, again, not just talk about asthma prevalence and compliance in total. Let's break apart those averages. Let's look for outliers and focus on opportunities. Within asthma, which seems like a very common metric, high prevalence across the country, we see high variability in prevalence and in care. Let's start with ethnicity. A critical component of conversations that need to be had with employers is the disparities in care, the variety of care that exists based on the ethnicity of the patient being treated. If we start by just looking at the prevalence of asthma, you can see in this view that prevalence is not a one size fits all. The African American population within Health Action Council has a greater proportion of asthmatics in their population compared to Caucasian, Hispanic, or Asian populations. But it's one thing to have higher prevalence. It's another thing to talk about cost and adherence, and we'll dive into that in a moment. On the next slide, we take a look at some inequalities when it comes to income. Are there higher, lower prevalence rates within asthma as you look at income brackets? The chart on the left, which we'll show you a few different times for a few different conditions, looks at income brackets. On the far left is the lower income population. On the far right are the higher income populations. And there are some peaks and valleys, and the numbers jump around a little bit, but in general, in comparison to what you'll see in the future around diabetes and hypertension and so on, a relatively flat line. It doesn't really change a lot based on income. There's a little bit more in the lower income population, but not a distinct linear curve that we see within this chart. We definitely know that there are different hotspots of asthma prevalence in different markets and different communities. We listed some of those on the right-hand side of this view as well. In general, Health Action Council has a little bit less prevalence of asthma than we see across a normal commercial population. But the next view allows us to look at how the treatment paths are different. And specifically, we're going to focus on flare-ups. Those asthma patients that become so severe in nature that they require treatment for what's defined as a flare-up. And here we see great variety of care, big variances based on both ethnicity and income. The African American population, when compared to the Caucasian population, has 15% higher rate of flare-up within that population. And if you look at it from an income perspective, the lower income population has a 23% greater proportion of flare-ups within that group. So both ethnicity and income show not only that there is higher prevalence, but also that there are worse treatment paths that are occurring within those populations. And then finally, the next view looks at what sort of prescription variability. Again, with help from OptumRx, we're able to look at prescribing patterns among these populations. So for this, we're going to really focus on the prescription of inhaled steroids within these populations. And again, the African American population is prescribed inhaled steroids less often, and higher income populations are prescribed inhaled steroids more often. Same sort of disparity, higher prevalence, higher incidence with asthma within these populations. We see that the care patterns are a little bit worse within those populations, and the prescription pattern is not ideal as well. So leading down the road of leading to some potential barriers to care for these populations. Next slide. Last but not least, as we look at it, not only did they receive a prescription, but what sort of adherence do they have? And there's lots of ways to look at adherence, but when we look at pharmacy data, there are three pillars of adherence. We're going to look at what we call primary medication adherence. We're going to look at the proportion of days covered, and then we're going to look at the percent of those members that are adherent. So just as a brief outline on these numbers can be confusing, but on the left-hand side, when you look at primary medication adherence, this is really looking to see for that first fill. Did that member that was just diagnosed with asthma, did they fill the prescription for that medication? In the middle, the proportion of days covered is really looking to see of 365 days in the year, how many days did you have a dose available for you as an asthmatic to use? So the goal being about 80% of the days to have a prescription on hand for that asthmatic. And then on the far right is really just looking at those two metrics. How often does that happen? So for the Health Action Council population, we see that in total, about 65% of the time of members are adherent to that metric, which is higher than we see across our book of business. And each one of these metrics are better than our book of business. So asthmatics and Health Action Council do better than expected. But again, we still see a variety of care and some opportunities in some of those subpopulations of need. With that, I'll take a little break and I'll pass the ball back to you, Angela, and you can walk through the next condition.
So let's take a couple of minutes and think about back disorders. You know, as Craig said, these are some of the most prevalent things that happen to employees. And so when you think about back disorders, first, again, this is the same view of socioeconomic and geographic factors. But if you will look at the line on the back disorders, it's very different than what you saw in asthma. So back disorders show us that there is a direct correlation to the income bands, meaning that those people with the highest rates earn the least. And keep these views in mind, because you're going to see this view particularly again as we talk. Now, a thing that's interesting about the locations where these back disorders are most prevalent for Health Action Council is that many of these areas, Northeast Tennessee, near where I am, Jefferson City, Missouri, parts of Ohio, these are all places with a significant manufacturing presence. And one of the things that we studied as part of this is what kinds of jobs cause people the most back pain. And factory work turns out to be one of those jobs that cause people the most back pain. Now, this is interesting. This is a different kind of care and treatment gap than we saw in ASBA. But if you think about people who have back pain or back disorders, they go to the emergency room and they go to urgent care far more frequently than the average. So you see the Health Action Council average on the far left, and those 2 or 3 columns over show you the people who have tried physical therapy or chiropractic care versus those who have not tried physical therapy or chiropractic care. And there's a few takeaways here. The first is the people who try physical therapy and chiropractic care, their rates are lower than those people who don't try that. But when you look at that orange line, so, I know some of you heard our talk on virtual visits last year, and we never knew that they would become so relevant as they have in this year. The orange line here is virtual visits and people who also try PT and chiropractic care. So what we think this shows, because they have the highest rate, is that those types of folks have a propensity for certain people really to just seek a less aggressive, less costly kind of care overall. This is a strange correlation, but it really was there. And it was one of the interesting, uncommon things we found in the data. Now let's talk about diabetes. So there's a multitude of diabetes information programs that you as employers get from our organization and many others that are vendors that are, the American Diabetes Association, those sorts of things. This is information very similar, socioeconomic and geographic factors. Again, you see direct correlation between the lowest income bands and those people who have the highest rates of diabetes. Now, for the Health Action Council membership, diabetics are most prevalent in areas of the South, rural areas, places that are known for high diabetes prevalence. That is true for the Health Action Council membership. But here is something uncommon. So it is very rare for employer groups, insurers like us, to talk about their Asian members. Typically, those are very small populations. You see it's 3% for the Health Action Council. But what we have found, and what we found through some study, is it is very common for Asian diabetics to have the highest prevalence of diabetes. And there's a really interesting study that we looked at as part of this that was in part done by Harvard. And what it found is that the reason that Asians have such high rates of diabetes is diet-related, lifestyle-related like smoking, and genetics. And so we wanted to know, is this true? Is this true for Health Action Council's diabetics? And it was. You see that rate is 43% higher, the prevalence. But this is where it gets really interesting. So when we think about care and treatment gaps for diabetics, the rates for Asians are far higher than any of the other racial and ethnic groups. But also their performance in diabetic testing and screening is higher. You see there at left a list of the tests or screenings that all diabetics should have every year or two, depending on what the test is. And you see there that the rates are so much higher for Asians in every single category. The lowest performing groups, Hispanic, Caucasian, Hispanic, it's a variety. But overall, every single group did, every single test, they did better for these screenings. So we thought about, why is this true? What would have caused this? And so some of the theories that we came up with were, it could be the provider that is ordering the test. It could be culturally instilled compliance that is true of Asians. it could be educational. And so one of the things that we studied is that in America, Asian Americans are 4 or 5 times more likely to be college educated than Hispanic Americans. And so that health literacy could be driving some of these personal decisions that affect the testing and the screening. Once again, though, this rate of adherence to medications is excellent. The Health Action Council members who are diabetic do better than typical rates. They do better than the OptumRx rates. Once prescribed, they do a fantastic job of taking the medication. Now let's talk a little bit about hypertension. So as we saw in asthma, there is a direct disproportionate share for African-American Health Action Council members overall. That rate is 63% higher for those members who have hypertension. This is probably something that you have seen in different kinds of reports. This is not an uncommon finding, but this is the first time we've actually seen that in our own Health Action Council information. Once again, you get that direct correlation between those who have the lowest income levels have the highest rates. So within Health Action Council, you do see quite a lot of hypertension. It is, again, areas of the South, rural areas are the highest, but this is very diversely spread across the country. Those rates are significantly higher with age, and they do vary with other social determinants. But one thing to know is only 13% of Health Action Council members have hypertension. And if you go by the most current rates for the American Heart Association, that's about 45% in the country. And there is some discrepancies. There's some discussion about what is the right rate to look at. But if you go by that rate, only 13% of Health Action Council has hypertension. Now, this is perhaps the most interesting slide in the whole deck. I'm going to take a few minutes and explain it to you because it's very detailed. But here's what I want you to know. So what we looked at is prescription variability between males and females, and also in different age brackets. So what you see at left is males and females who are under the age of 60, and at right is males and females who are over the age of 60. Now, one thing to point out first off is in the gray sections, you will see that in the ACE, the ARB, and the statin drugs, males are prescribed more than females no matter what across the board. Well, let's look at that third category. So the third category is people who are hypertensive, but they've also had a heart attack. Now, I will note that there's only one place on this screen where you see females prescribed more, and that is younger females who have had a heart attack get the drugs a little bit more than younger males do. But here's where it really gets interesting and quite frankly discouraging. So if you look at the difference between younger females and older females, that's a 20 percentage point difference. Or what about the difference between older females and older males? That's a 23 percentage point difference. So this is the standard of care. The standard of care is that everyone get a beta blocker after a heart attack. And you can see how widely varied that is. And these numbers were so startlingly different that we reached out to some of our medical directors and said, what is this? Why are these numbers so bad? And we very quickly got answers from a few of them. Nobody's surprised by these findings. You know, it is well known that women are suboptimally treated for hypertension and heart disease. And so one of the things that we want to say is this is the sort of variance we intended to reveal with this study. And these are your employees. These are your wives. These are you. These are the kinds of things that we don't often shed a bright light on when we look at the data, but we should be. Now, these are the sorts of things that we want to fix. The great news is if the medicine gets prescribed, the medicine gets taken. And that is a general truism for all of Health Action Council. Now I'm going to pass this over to Craig to talk to you a little bit about mental health and substance abuse.
Thank you, Angela. We certainly have covered a lot today, and we don't mean to put mental health last, and obviously is a top priority, but we definitely see that there's a wide variety of care within mental health and substance abuse as well. So let's dive in. And as you think about behavioral health, there, as you know, there's a wide variety of different care that's out there, and this has changed a lot over time. Think back to our generational analysis as the Gen X's of the world are taking over the world. We see that behavioral health is going to become a big theme of what we talk about, and obviously COVID has driven that to extremes. But as we take that same sort of structure and start to cut and slice the behavioral health incidents, you can see first thing that jumps out on the page to me is that income matters. The prevalence of behavioral health is definitely skewed towards the lower income population, goes down as you go into the higher income brackets. It's different by different geographies. We see some hotspots in Ohio and Indianapolis, and we see that there are some differences between rural and urban, which on the next slide, you'll see it's a little bit about prevalence between the rural and urban populations. There's a little bit skewed towards rural, having a little bit more of behavioral health issues, mental health issues within those populations. But it really gets down to the outcomes. How are they treated? Access to care, things like that. You can see that people with behavioral health issues struggle more in the rural areas when it comes to key themes like emergency room utilization, having to be admitted, and even the ability to engage in clinical programs. It varies by for those communities. So there might not be as big of a barrier as far as prevalence necessarily, but the outcomes are very different when you live in a rural community. So it's not just about age and gender and ethnicity, but again, where you live can be a key variable to look for variances within this data. In the next view, we look again back to adherence, and we start to see how our, first of all, Health Action Council members do very well when it comes to behavioral health adherence to medications. But there are some opportunities, and you can see on here, for example, we have 78% of the members being adherent with these metrics. Obviously, an opportunity better than average, but we want to keep nudging that higher and higher. So as we take a step back and kind of think about final thoughts, first of all, we haven't talked about COVID much. I mentioned it once. We didn't want to focus on COVID, and intentionally we looked at the most of this experience is pre-COVID because COVID would have skewed all this data, and we really wanted to have it be a much tighter analysis focused on the abnormalities we see in some of these common conditions. But just note, as you think about what impact would COVID have had on this analysis, if anything, COVID-19 has taught us that in healthcare, there are wide disparities of care. COVID itself, as far as the prevalence disparities, let alone the mortality disparities, are obvious and just shine a light on the issue that hopefully we've shown you through this white paper. We could talk about this all day. I won't bore you with all the details. There's lots of materials. We will have the full deck, the full research deck that goes beyond all the data that Angela showed you today, as well as views of some of the 7 tips of what do I do with this? How do I start to act upon this data? As you think about what to take away from this discussion through this white paper is we need to look at subpopulations. We need to break apart the averages. We need to stop peanut butter spreading our solutions everywhere. Let's use the power of our data to find those outliers, find those communities of greatest need, and then let's focus our solutions specifically on those communities and help improve the healthcare and the health outcomes of those populations. And with that, thank you so much for attending, and hopefully you will enjoy the rest of the details you can find on the website.